Have you ever wondered if the routine health tests you've trusted for years could actually be robbing you of your vitality, sparking unnecessary fear, and even shortening the joyful years you have left? In a world obsessed with early detection, it's shocking to learn that after 70, some of these very screenings, like PSA tests, colonoscopies, and full body scans, can trigger a cascade of overdiagnosis, invasive procedures, and side effects that do more harm than good, all backed by studies from top medical institutions and real stories from seniors who've regretted saying yes. Stick with me until the end, because I'll reveal the 5 most overpushed tests to avoid, plus simple, empowering questions to ask your doctor that could safeguard your independence, peace of mind, and quality of life, turning potential pitfalls into a roadmap for truly thriving in your golden years. Before we begin, I would appreciate it if you like this video. You can help me continue to spread the old age lesson. If you haven't subscribed yet, I recommend you subscribe and turn on the bell so you don't miss any videos. If you like this video, please comment number 1. If you don't like it, comment number 0 to let me know, so I can make a better video for you. Now let's get started. Number 1. PSA testing for prostate cancer after 70. In the landscape of preventive healthcare, few tests carry the weight of familiarity and reassurance quite like the prostate-specific antigen, PSA, screening for men over the age of 50. This straightforward blood draw has become a staple in annual physicals, offering a seemingly simple metric to gauge prostate health and flag potential cancers in their nascent stages. For countless men, that single number on a lab slip has symbolized vigilance, a proactive step toward longevity, whispered about in doctors' offices and men's health magazines alike. Yet, as the calendar turns and men cross the threshold into their 70s, the narrative shifts dramatically. Persisting with PSA testing as a default ritual, without pausing for a nuanced evaluation, can inadvertently steer individuals toward a cascade of interventions that erode well-being rather than enhance it. The issue isn't the test's inherent value. It's the downstream ripple effects, the biopsies, treatments, and emotional toll that can ensnare older adults in a web of avoidable complications. At its core, the PSA test quantifies levels of prostate-specific antigen, a protein naturally secreted by cells in the prostate gland to support reproductive functions. While spikes in PSA can indeed signal the presence of prostate cancer cells churning out excess protein, this marker is far from a crystal ball. Benign prostate hyperplasia, BPH, a non-cancerous enlargement common in aging men, urinary tract infections, prostatitis, inflammation of the prostate, or even recent physical activities like cycling, can elevate readings, mimicking malignancy. This ambiguity renders the PSA test particularly susceptible to false positives, where up to 75% of abnormal results in older men turn out to be false alarms upon further scrutiny. The fallout? A torrent of anxiety-provoking callbacks, often culminating in invasive biopsies. These procedures involve extracting tissue samples via a needle guided through the rectum, exposing patients to risks such as urinary tract infections, affecting up to 5% of cases, significant bleeding, sepsis in rare but severe instances, and prolonged discomfort. If a diagnosis is confirmed, frequently of the low-grade variety, it may propel men toward aggressive therapies like radical prostatectomy, surgical removal of the prostate, or external beam radiation. These, in turn, boast side effect profiles that strike at the heart of daily life. Urinary incontinence that necessitates pads and erodes confidence, erectile dysfunction that strains relationships, bowel irregularities from radiation scatter, and even secondary cancers from prolonged hormone therapies. For men in their 70s and beyond, the calculus of benefit versus burden tilts decisively. Prostate cancers detected via PSA often belong to the indolent subtype, slow-growing tumors that may smolder harmlessly for decades, outpacing a man's natural lifespan without ever metastasizing or causing symptoms like bone pain, urinary obstruction, or fatigue. Autopsy studies reveal that up to 50% of men over 70 harbor such microscopic cancers undiagnosed in life, underscoring how detection doesn't equate to destiny. Overtreatment in this demographic, driven by screening zeal, thus forges a path of diminished vitality. Months of recovery from surgery, the psychological sting of sexual dysfunction, and the regret of trading symptom-free years for procedural scars. Large-scale research, including the European Randomized Study of Screening for Prostate Cancer, ERSPC, and the U.S. Prostate, Lung, Colorectal, and Ovarian, PLCO, Cancer Screening Trial, has illuminated this paradox. They demonstrate that while PSA screening modestly curbs prostate cancer mortality in younger cohorts by about 20% in some analyses, it yields negligible survival gains in men over 70, yet amplifies harms, with complication rates climbing as comorbidities like heart disease or diabetes compound vulnerabilities. The net result: heightened chronic anxiety from watchful waiting limbo, escalated healthcare costs, and a measurable uptick in iatrogenic, treatment-induced suffering, all without a commensurate extension of healthy years. To bring this into sharper relief, consider the poignant journey of James, a 74-year-old retired high school teacher from a quiet Midwestern suburb, whose evenings once revolved around grading papers, gardening, and quiet dinners with his wife of 45 years. A creature of habit, James had faithfully submitted to annual PSA checks since turning 55, viewing each as a badge of diligence. His numbers had hovered in the safe zone, a comforting constant amid life's transitions. Then, one crisp autumn routine visit unearthed a PSA of 8.2 nanograms per milliliter, well above the typical threshold, triggering a whirlwind of consultations. The subsequent transrectal ultrasound-guided biopsy, performed under local anesthesia in a sterile clinic room, confirmed a Gleason score 6 tumor, low risk, confined, and unlikely to progress aggressively. Armed with brochures and statistics, James deliberated his path. Opting for the perceived security of intervention, he underwent robotic-assisted prostatectomy at a renowned medical center. The surgery was deemed a technical triumph, excising the offending gland with precision. But the aftermath unfolded like a slow unraveling. Catheters for weeks, episodes of leakage that confined him to the house, and a profound erectile dysfunction that dimmed the spark in his marriage. Physical therapy helped marginally with continence, but the emotional chasm lingered, nights spent questioning if that elusive cure had stolen more joy than the unseen cancer ever could. James's story echoes thousands, a testament to how well-intentioned screening can fracture the fragile mosaic of later life fulfillment. In light of these insights, contemporary medical consensus has evolved toward restraint. The U.S. Preventive Services Task Force, USPSTF, American Urological Association, AUA, and American Cancer Society, ACS, now advocate shared decision-making for PSA screening in men over 70, urging a halt to routine use absent compelling symptoms like persistent pain or hematuria, blood and urine. This paradigm prioritizes holistic assessment, gauging life expectancy, e.g., via tools like the Charlson Comorbidity Index, appraising frailty through metrics such as grip strength or gait speed, and aligning choices with personal values, be it cherishing travel with grandchildren over hypothetical longevity gains. The ethos? Precision over protocol, ensuring that interventions amplify rather than attenuate life's closing chapters. Thus, for men navigating their 70s or the loved ones charting their course, the mantra bears repeating. Escalation isn't synonymous with enlightenment. PSA testing, once a beacon, can morph into a siren call of superfluous scrutiny, breeding distress and debility where serenity should reign. The truest safeguard lies in dialogue, a candid exchange with your provider, probing the tailored necessity of that draw. In an era where overtreatment claims an estimated 30% of prostate cancer cases, opting out can be the apex of acuity. This isn't a summons to complacency. It's an invitation to discernment. Because beyond 70, the paramount pursuit isn't mere endurance. It's embracing each day with grace, unburdened by the shadows of unneeded battles. Number 2. Routine colonoscopies past 75. Parallel to the PSA saga, routine colonoscopies stand as another pillar of longevity lore, lauded for over 4 decades as the preeminent sentinel against colorectal cancer, one of the most preventable malignancies through timely intervention. This endoscopic odyssey has rightfully earned its accolades. By visualizing and excising precancerous polyps during the procedure, it slashes mortality risk by up to 60% when timed optimally in midlife. For those who've adhered to the 10-year cycle from age 50, the payoff is tangible. Lives extended, families spared grief. However, as the odometer ticks past 75, this gold standard tarnishes. The incremental value of repeat screenings wanes precipitously, while the specter of adversity looms larger, particularly for individuals with unblemished prior exams. Here, the scales tip. What once fortified health can, in later years, fracture it. If you are still watching this video and finding these lessons useful, please comment number 1 below to let me know that you are still watching this video with me. Thank you for your valuable time. Unpacking the mechanics reveals why. A colonoscopy transcends a mere diagnostic glance. It's a meticulously orchestrated invasion of the gastrointestinal tract. Patients endure a grueling bowel prep, chugging liters of osmotic laxatives that induce exhaustive diarrhea to cleanse the colon, followed by intravenous sedation to blunt the discomfort of a colonoscope serpentine journey from anus to cecum, snaking some 5 feet through mucosal folds. For the robust middle-aged, this is an inconvenience. For the septuagenarian or octogenarian, it's a gauntlet. Age amplifies perils. The perforation risk, though low at 0.1 to 0.2% overall, escalates with bowel wall thinning and motility slowdowns, potentially necessitating emergency surgery. Sedation mishaps, respiratory depression or paradoxical agitation, strike harder amid polypharmacy and reduced organ clearance. Post-procedure bleeding from polyp removal, dehydration from PrEP, or falls during recovery further compound the toll, with hospitalization rates doubling in those over 75 compared to younger peers. Frailty metrics, like the Fried phenotype, encompassing exhaustion, weakness, and slowness, predict these escalations, as does comorbidity burden. Think concurrent atrial fibrillation or osteoporosis, where even minor insults cascade into major setbacks. Compounding this is the epidemiological nuance. Colorectal cancer incidence climbs with age, peaking in the 80s, yet so does the prevalence of indolent lesions. Polyps that, if detected, might never evolve into symptomatic disease within a finite lifespan. For a 76-year-old with a decade of clean scopes, the 10-year risk of advanced neoplasia hovers below 5%, per models from the National Polyp Study, while complication odds nudge toward 1 to 2%. Many elders, steeped in a cultural ethos of test early, test often, overlook this equilibrium, equating vigilance with virtue. Yet data from the U.S. Surveillance, Epidemiology, and End Results, SEER program and the Nordic European Initiative on Colorectal Cancer, NORD-ICC, trial paint a sobering portrait. In the over 75 cohort, screening confers at most a 1 to 2% absolute mortality reduction over a decade, dwarfed by a 3-5-fold hike in adverse events. The upshot? A regime that trades vitality for vigilance, where the cure imperils more than the condition. Illustrating this human dimension is Margaret, an 80-year-old grandmother from a sun-dappled Florida retirement community, whose days brimmed with bridge games, volunteer shifts at the local library, and spoiling her great-grandchildren with homemade lemon bars. A paragon of compliance, she'd marked her calendar for colonoscopies every 5 years since 55, crediting the ritual with her robust health. Her most recent outing, at 75, yielded pristine results. No polyps, no red flags, prompting her gastroenterologist to float another at the decade's cusp, just in case. Dutiful as ever, Margaret prepped meticulously, fasting through cherished family suppers and enduring the ritual's rigors in a bustling endoscopy suite. The scope advanced smoothly until a subtle snag, a microperforation in the sigmoid colon, a hairline tear from frictional stress on atrophied tissue. What followed was a blur of 4 antibiotics, surgical consults, and a 2-week inpatient stay, punctuated by fevers, unrelenting abdominal cramps, and the sterile chill of hospital gowns. Mercifully, no cancer lurked, but the ordeal etched deep. Mobility curtailed by pain meds, a fortnight sideline from her joys, and a newfound wariness that chipped at her independence. Margaret's ordeal, far from anomalous, mirrors the plight of thousands, where the guardian procedure becomes the unwitting adversary, siphoning sparkle from golden years not through disease, but through its zealous pursuit. Heeding these harbingers, authoritative bodies like the USPSTF, American College of Gastroenterology, ACG, and Multi-Society Task Force on Colorectal Cancer now delineate age 75 as a de facto terminus for routine colonoscopy in average-risk elders with negative histories. Exceptions carve space for symptoms: persistent diarrhea, rectal bleeding, iron deficiency anemia, or nocturnal bowel urgency, as harbingers warranting targeted probes like CT colonography or fecal immunochemical tests, FIT, which sidestep sedation's perils. This pivot champions individualized blueprints, factoring in performance status via the Eastern Cooperative Oncology Group, ECOG scale, estimating remaining years through actuarial tables, and honoring preferences, perhaps prioritizing pain-free outings over polyp patrols. The imperative: discernment over dogma, ensuring diagnostics serve as allies, not overlords. No soul yearns to court calamity, yet in the autumn of life, the shrewdest wager often whispers restraint. Beyond 75, horizons broaden from combative canvassing to custodial care, safeguarding the essence of existence against procedural pitfalls. Engage boldly. Query your clinician on risk-benefit ledgers, explore less invasive sentinels if vigilance calls, and affirm when pause prevails. This discourse dispels dread, arming you with acumen. It's a homage to your vessel's vicissitudes, crafting choices that venerate yesteryear's vigor and tomorrow's tranquility. In the end, health's true measure isn't the tests tallied, but the life they let you live, vibrant, unencumbered, and wholly yours. Number 3. Full-body CT scans without symptoms. In our modern era of advanced medical technology, it's easy to fall into the trap of thinking that more diagnostic imaging equates to better health outcomes. The allure is undeniable. Advanced machines capturing detailed images of your entire body, generating reams of data that promise to uncover hidden threats, and offering a sense of security through early detection. Full-body CT scans, in particular, are marketed as a proactive shield, potentially spotting cancers, aneurysms, or other serious conditions long before they manifest as noticeable symptoms. Yet, for seniors over the age of 70 who are otherwise healthy and symptom-free, this seemingly comprehensive approach often proves to be a double-edged sword, tipping the scales toward harm rather than benefit. The primary concern starts with the radiation exposure inherent in these scans. A single full-body CT delivers a dose of ionizing radiation equivalent to hundreds of standard chest X-rays, roughly 10 to 20 millisieverts, depending on the protocol. While a one-time scan might seem negligible, repeated exposures over the years can accumulate, subtly elevating the lifetime risk of radiation-induced cancers, such as leukemia or thyroid malignancies. It's a poignant irony. The tool designed to hunt for cancers could, in fact, contribute to their development, especially in older adults whose bodies may be less resilient to such cellular damage. Even more troubling, however, are the incidental findings that frequently emerge from these scans. Those unanticipated anomalies like small nodules in the lungs, benign cysts in the kidneys, or shadowy spots on the liver that appear unrelated to any presenting issue. In seniors, these are exceedingly common, often stemming from the body's natural aging processes. Scar tissue from resolved infections, fatty deposits, or age-related calcifications that pose no threat. Yet, the discovery of such incidentalomas rarely ends with the initial scan. Medical protocols typically mandate follow-up investigations to rule out malignancy, sparking a relentless chain of events. Additional imaging with even higher radiation loads, blood tests, endoscopies, or invasive biopsies. Each step introduces its own perils. Infection risks from procedures, allergic reactions to contrast dyes, financial burdens from escalating costs, and the profound emotional strain of living under a cloud of uncertainty. This phenomenon is broadly termed overdiagnosis, where clinically insignificant conditions are identified and pursued as if they were life-threatening. For older adults, whose remaining lifespan may be shorter, the window for these harmless findings to evolve into problems is often narrow. Instead of extending healthy years, the pursuit can erode them through unnecessary interventions. The psychological ramifications are equally severe. The gnawing anxiety of awaiting results, the disruption of daily routines with endless appointments, and the erosion of trust in one's own body. Physically, complications like post-biopsy bleeding, anesthesia reactions, or surgical scars add tangible burdens, sometimes leading to reduced mobility or chronic pain that overshadows any preventive gain. To illustrate, consider Martha, a vibrant 76-year-old grandmother who spent her days gardening and volunteering at the local library. Eager to stay ahead of her health, she opted for a full-body CT scan during her annual wellness visit, drawn in by glossy brochures touting total body assurance. The results lit up with a 5mm nodule in her right lung, a tiny, irregular shadow that caught the radiologist's eye. Though statistical models pegged the odds of it being cancerous at under 1% for someone like Martha with no smoking history or risk factors, her physician, bound by cautionary guidelines, advised a needle biopsy to confirm. The outpatient procedure, meant to be straightforward, took a harrowing turn, a collapsed lung from the puncture, followed by emergency chest tube insertion and a 3-day hospital stay. Weeks of recovery sapped her energy, sidelining her beloved activities and plunging her into a spiral of sleepless nights haunted by what-ifs. Follow-up scans a year later confirmed the nodule was stable and benign, a mere artifact of an old, forgotten respiratory bug. Martha's story isn't rare. It's a cautionary echo of countless others where the quest for certainty unearthed only needless suffering. Prominent medical organizations, including the American College of Radiology and the U.S. Preventive Services Task Force, have issued strong advisories against routine full-body CT scans in asymptomatic adults over 70. Their consensus is clear: without targeted risk factors, like a strong family history of cancer or genetic predispositions, these scans lack evidence of net benefit and amplify harms. A more judicious path forward emphasizes personalized screening. mammograms for those with breast cancer history, colonoscopies for polyprone individuals, or low-dose lung CTs solely for heavy smokers. This tailored strategy prioritizes tests backed by rigorous trials showing mortality reductions, while minimizing exposure to radiation and procedural risks. It fosters a partnership between patient and provider, where decisions hinge on individual context rather than one-size-fits-all protocols. If you're navigating your 70s or beyond and pondering a full body scan, pause for reflection. Pose these pivotal questions to yourself and your doctor. What specific conditions are we screening for, and how probable are they in my case? Would the results genuinely alter my management plan, or just prompt more tests? What are the cumulative radiation risks, and how do they stack up against my personal health profile? Often, the wisest course lies in vigilant symptom monitoring, tracking unexplained weight loss, persistent fatigue, or digestive shifts, coupled with biannual physicals and lifestyle safeguards like a nutrient-rich diet and regular movement. In the end, true peace of mind blooms not from exhaustive imaging but from balanced vigilance that honors the body's wisdom without overwhelming it. If you are still watching this video and finding these lessons useful, please comment number 2 below to let me know that you are still watching this video with me. Thank you for your valuable time. Number 4. Annual chest X-rays for lung cancer screening in non-smokers. In the landscape of preventive medicine for older adults, few practices seem as intuitively sound as annual chest X-rays to keep a watchful eye on lung health. For many seniors who've reached their 70s or 80s without a blemish on their smoking record, these quick, low-cost snapshots are positioned as a simple safeguard, a yearly ritual to detect lung cancer in its nascent stages, intervene swiftly, and potentially avert tragedy. The logic feels airtight. Early discovery equals early treatment, which in turn saves lives and preserves independence. However, for non-smokers over 70 lacking other high-risk markers like occupational exposures to asbestos or radon, this routine has a darker underbelly, frequently delivering more detriment than defense. At their core, chest X-rays are a blunt instrument for lung cancer surveillance, particularly in those without symptoms. Their sensitivity hovers around 50 to 70% for early-stage tumors, meaning they routinely overlook subtle infiltrations while spotlighting benign quirks that mimic malignancy. Common culprits include calcified granulomas from healed tuberculosis, fibrotic scars from childhood viruses, or even age-related pleural thickening, artifacts as innocuous as they are prevalent in aging lungs. When these false positives surface, they seldom fade into the background. Instead, they ignite a domino effect of escalatory diagnostics. A flagged shadow might escalate to a high-resolution CT scan, with its amplified radiation, positron emission tomography for metabolic activity, bronchoscopy with tissue sampling, or, in extreme cases, thoracotomy for surgical exploration. Each escalation layers on hazards: cumulative radiation that compounds cancer odds, procedural infections, pneumothorax from needle aspirations, or anesthesia-related cardiovascular strain in frail elders. Beyond the tangible perils, the ripple effects on daily life are insidious. Overtreatment siphons time and resources, pulling seniors from cherished pursuits, family gatherings, gentle walks in the park, or quiet evenings with a book, into a vortex of clinical limbo. The financial sting, even with insurance, mounts through co-pays and lost wages from recovery. But the stealthiest thief is psychological. The jolt of a suspicious finding unleashes a torrent of dread, manifesting as insomnia, appetite loss, or hypervigilance over every cough. This chronic stress doesn't dissipate post-clearance. It lingers, fraying resilience and sometimes catalyzing isolation as loved ones tiptoe around the scare. Picture Helen, an 82-year-old retired librarian whose shelves of well-thumbed classics spoke to a life of quiet intellectual passion. Faithful to her primary care routine, she submitted to yearly chest X-rays, viewing them as a harmless nod to prudence. On a crisp autumn morning, the film revealed a faint opacity in her left upper lobe, a 1-centimeter haze that the radiologist couldn't dismiss. Referred to pulmonology, Helen endured a gauntlet, a contrast CT that left her queasy from dye, a PET scan probing for spread, and finally a transbronchial biopsy under sedation. The needle's graze sparked a minor bleed, confining her to bed rest and pain meds for a fortnight, during which her once steady hands trembled too much for knitting. The verdict: a dormant histoplasmosis scar from a decades-old Midwest exposure, utterly harmless. Yet, the ordeal etched deep grooves. Helen's once curious spirit dimmed, her library visits curtailed by fatigue, and a shadow of suspicion now colored her breath. Her tale underscores a systemic pitfall, where vigilance veers into vigilantism against one's own well-being. Guiding bodies like the National Comprehensive Cancer Network and the American Cancer Society have crystallized their stance. Routine chest X-rays confer no survival edge for low-risk seniors and should be shelved in favor of precision-targeted protocols. Low-dose CT screening shines for the select few, those with 20-plus pack years of smoking history who quit within the last 15 years or persist as current users. But for the vast non-smoking majority, the equation flips to net harm. This isn't a blanket rejection of care, it's a clarion call for discernment, weighing evidence from landmark trials like the National Lung Screening Trial, which spotlighted CT's niche efficacy while indicting X-ray's futility. Navigating this terrain demands empowerment through inquiry. Before greenlighting that next annual X-ray, lean into dialogue with your provider. Given my non-smoking background and clean history, what's the realistic yield of this test for me? How do the downsides, radiation buildup, false alarms, procedural cascades, compare to any upsides? Might watchful waiting or symptom-driven evaluations suffice? Informed consent isn't a mere formality. It's the fulcrum for reclaiming agency. Ultimately, safeguarding lung vitality post-70 thrives on holistic fronts. Shunning secondhand smoke, embracing anti-inflammatory foods like berries and greens, and incorporating breathwork or Tai Chi to bolster respiratory reserve. It's a reminder that health's guardians aren't always machines, but the measured choices that let life unfold unencumbered. Number 5. Routine cognitive testing without symptoms. As the calendar pages turn into the 8th decade and beyond, many seniors encounter an unexpected ritual in their primary care visits. A suite of cognitive assessments slipped into the flow of blood pressure checks and flu shots. These mini-exams, quick-fire questions on recalling words, drawing clocks, or naming animals, aim to ferret out brewing dementia, even in the absence of telltale slips like misplaced keys or wandering conversations. The intent is noble, to illuminate early cognitive erosion and chart a proactive course. Yet, for those over 70 basking in symptom-free clarity, this blanket screening often backfires, sowing seeds of doubt, self-doubt, and distress that overshadow any speculative gain. Cognitive batteries like the Mini Mental State Examination or Montreal Cognitive Assessment are finely tuned for flagging overt declines, but in asymptomatic elders, they snag on the threads of normalcy. Aging's tapestry includes subtle shifts, a fractional lag in word retrieval, a momentary pause in multitasking, or the odd, tip-of-the-tongue frustration that mirror life's ebb without heralding pathology. These variances stem from benign culprits, a recent cold dulling focus, polypharmacy fog from multiple meds, or even the brain's adaptive pruning to prioritize wisdom over rote speed. When such blips register as borderline, they invite hasty labels, transforming everyday lapses into harbingers of doom and igniting a maelstrom of misattribution. If you are still watching this video and finding these lessons useful, please comment number 3 below to let me know that you are still watching this video with me. Thank you for your valuable time. The fallout cascades swiftly. A flagged score can pierce self-esteem, branding vibrant individuals as at risk and curtailing pursuits that fuel fulfillment. Leading book clubs, mentoring grandkids, or tackling puzzles. The stigma lingers, whispering isolation. Am I still me? Anxiety spikes cortisol, which in turn hampers hippocampal function, creating a vicious loop where worry begets the very fog it fears. Depression may entwine, sapping motivation for exercise or social bonds that are cognitive elixirs. And in a landscape where disease-modifying therapies for preclinical Alzheimer's remain elusive, despite promising trials with anti-amyloid drugs, these revelations rarely pivot to actionable cures, leaving patients adrift in limbo with more questions than answers. Envision Sarah, a 75-year-old retired nurse whose career had honed her into a beacon of composure amid chaos. At her semi-annual checkup, her doctor, aligning with emerging brain health protocols, administered a 10-minute cognitive panel, just to baseline things. Sarah aced most, but stumbled on serial 7s and a recall task, netting a score teetering on the cusp. The physician's gentle caveat, "It could be nothing, but let's monitor," unleashed a torrent. Sarah cataloged every minor oversight, from forgetting a neighbor's name to hesitating on a recipe step, her journal filling with frantic notes. Social invitations withered as she demurred, fearing judgment. Sleep fractured under rumination. It took a geriatric neuropsychologist 3 months later to reframe the results. Age norm charts showed her performance squarely in the robust range, her lapses mere echoes of a mind juggling decades of expertise. Yet, the interim erosion was indelible. Sarah's once effortless laughter now laced with hesitation, her garden untended amid the mental melee. The Alzheimer's Association and geriatric societies like the American Geriatric Society advocate restraint. Reserve formal testing for those voicing concerns or exhibiting functional hiccups, such as bill-paying errors or navigational snafus. For the asymptomatic cohort, the harm-benefit ledger tilts red. Overtesting inflates false positives, up to 20% in healthy seniors per studies, without slashing dementia incidence. Wisdom lies in upstream fortification. Mediterranean diets rich in omega-3s, aerobic pursuits that vascularize the brain, Mediterranean sleep hygiene, and communal ties that stave off atrophy. Cognitive reserve, built through lifelong learning, often trumps early alerts. In your 70s, if cognition feels steadfast, honor that intuition over obligatory probes. Challenge your care team. With no red flags in my daily life, does this screening align with my risks? How might a subtle dip skew my outlook, and what safeguards exist? Could lifestyle audits or informal chats reveal more without the formal weight? This dialogue demystifies, centering you as co-pilot. Cherish the brain's plasticity. Neurons forge new paths through novel hobbies, heartfelt dialogues, or even mastering a smartphone app. Aging isn't erosion but evolution, nuanced, resilient, and ripe for joy. Discernment here is paramount. Tests illuminate paths, but unbidden, they can eclipse the light within. Cultivate choices that affirm vitality, not audit it. As we come to the end of this video, take a moment to reflect on the power you hold in your health decisions. After 70, it's not about more tests. It's about smarter choices that let you live fully, freely, and without regret. What have you learned so far that resonates with you? Maybe it's the importance of questioning routine PSA tests, or the shift toward symptom-driven care over blanket screenings. We'd love to hear from you. Drop a comment below sharing one key insight from this video and how you'll bring it into practice in your life. Your story could inspire someone else watching right now. If you like this video, please leave your comment below, and don't forget to like, share, and subscribe to our YouTube channel for more empowering health tips tailored just for you. Thanks for joining us. Here's to your healthiest, happiest years ahead.